Good evening all. Welcome to iFocus Online, lecture 276. It's 17th in the Uvea module. Today we have with us Dr. Vishali Gupta from PGI Chandigarh to speak to us on ocular tuberculosis. May I request Dr. JB sir to please introduce the speaker for today.
Good evening. It's indeed a great pleasure and privilege to introduce somebody whom I have observed closely and seen him growing. And she is now the stalwart in uveitis globally, and not only in India. Undoubtedly is one of the topmost uveitis specialists, particularly authority in ocular tuberculosis. She had done her senior residency in vitreoretinal surgery in PGIMER, Chandigarh, and ICO fellowship in uveitis at Doheny Eye Institute, University of Southern California, under Professor Narsingh Rao. Currently, she is the Chief of Retina and Uveitis Services at Advanced Eye Care Center, PGIMER, Chandigarh. She is the principal investigator of many multicentric collaborative ocular study, and she had authored over 72 book chapters, edited 6 textbooks, delivered 875 invited lectures. Every time I listen to it, it's so clear and precise. I can't miss any of the talk. She received numerous awards and hold US patent for multiplex PCR. She had 281, if I am not mistaken, publication in peer-reviewed PubMed Index journals. She is an extremely good organizer and good communicator, and it's a great pleasure and privilege to introduce her. And we are all eagerly looking forward to listen to her on ocular tuberculosis, in which she is an authority, and this pioneering work, which has been acknowledged all over the world. Dr. Vishali Gupta, please. Over to you.
Dr. Biswas, it's always very humbling to be introduced by Dr. Biswas, sir, because he is the one who actually started serious uveitis in India. So thanks a lot, sir, for the very kind introduction. And thank you, Team iFocus, for inviting me to talk to the postgraduate students about ocular T. I have tried to make it simple, so I hope people can understand. So when we talk of TB uveitis is actually a confusing term, not only for the comprehensive ophthalmologist and students, but also for us uveitis specialists, and that is mainly because the diversity in the clinical phenotypes. Now, it's very difficult to differentiate whether the mycobacterium is present within the ocular tissue, or is it a heightened immune response without the mycobacterium invasion in the ocular tissue, or the recent thought processes that even is it an anti-retinal autoantibody response. Again, when we look at the patients who are IGRA positive, the prevalence of uveitis, TB uveitis based on the positive IGRA results, and if you exclude other infections, is low. But there are proportion of the patients of the IGRA positive patients who have the uveitis of unknown origin. Now, whether that is TB uveitis or not remains a $1 million question to answer. In other words, if you had listened to my talk about 5 years ago, or maybe even 2 years ago, the first slide of the talk always said that it is due to hematogenous dissemination of Mycobacterium T. But now I have added 4 more points because our understanding of pathogenesis is increasing. There is role of retinal pigment epithelium in Mycobacterium TB phagocytosis and orchestrating the immune responses. There are autoreactive intraocular T cells. There are various cytokines and substances in ocular fluids which are elevated, and that includes VEGF as well. There is granuloma formation from the histologic section, something which we knew always. So when we talk of what TB can produce in the eye, there are certain manifestations which are very classically TB and we call them horses. But there are a lot of zebras, and zebras are the ones like you have a patient with uveitis, you test for TB, it comes out to be TB positive, but the phenotype in the eye does not look like TB. So the question here is it TB or is it not? So let's go over some of the horses and then some of the zebras. Typical manifestation of the TB when it presents in the interior uveitis is the granulomatous variety of interior uveitis. So you see here mutton fat capes, and you see the nodules which are on the stroma, and these are called Bisaka's nodules. The nodules may be present at the pupillary margin, and these nodules, we call them as Cope's nodules. So what you will not always see, because many times the patient would have received steroids by the time you see. So you may not see the Cope's or Bisaka nodule, but you may see broad-based posterior synecdoche. And this is what the broad base is, like you have in the shape of a triangle with the broad base. Now, these are the manifestations which are very typical for tuberculosis. So when you look at a granulomatous interior uveitis, the most common chances of etiology in our country is TB versus sarcoidosis. So whenever you see granulomatous interior uveitis, the likelihood of TB is there. So it's important to get it tested for TB. This is something which we reported more than a decade ago, that what is the diagnostic accuracy of various anterior segment clinical signs for diagnosing tubercular uveitis. And you can see, as it has been highlighted, that broad-based posterior synecdoche, they had nearly 79% of positive predictive value with a confidence interval of 95%, which means a high with a great confidence. When you see broad-based posterior synecdoche, you can think about TB as a possible etiology. Now, I take you to another site. This is a young man, a 42-year-old man. He complains of sudden onset pain in the left eye, which is severe, which is acute. And it is so acute that he exactly remembers that it started in the evening at around 5 p.m. Now, when you look at the phenotype, you see acute eye and you see circumciliary congestion, you see fibrin, and you see endothelial dusting. You do not see granulomatous capes, or you do not see the nodules. So this is acute non-granulomatous interior uveitis. Now, this is the scenario where you don't even think of TB. So don't think of TB. There is absolutely no point in getting tests done for TB, because this is a phenotype when you will look for HLA-B27 positive or negative spondyloarthritis. So many times, like you see patients like this, simply because it is uveitis, people get tested for TB. And suppose this patient comes Monteus positive, would you treat it? No, because to get the test done, the first thing is your phenotype or your clinical presentation has to be suggestive of TB. If the clinical presentation is not suggestive of TB, there is no need to test for it. Or even if somebody else is tested for it and the patient is carrying the reports there is no need to treat as well. When we come to intermediate uveitis, now that is the more of a zebra, because in intermediate uveitis, unlike the anterior uveitis where we have granulomatous anterior uveitis as a very classical phenotype, in intermediate uveitis, honestly, it's always very confusing whether it could be TB or not TB. There are some clues which are more based on my clinical experience rather than anything. You see large snowballs in TB, unlike the autoimmune variety, and you don't see much of snow banking somehow. So if you have moderate to severe vitritis, large snowballs, no snow banking, and this is associated with peripheral vasculitis, you do have to think of TB and rule out TB as a possible etiology. This is an example of the patient on the top, which was diagnosed as TB, and this is the bottom after treatment with anti-TB drugs. Now, as we move on to the choroid, we have two very, very prominent features in TB, that is miliary tubercles like these, or a large tuberculoma. Now, once you see either a tubercle or a tuberculoma, there is no question. This is not zebra. This is straight away a horse. It is TB. You will look for the systemic disease. You will investigate for TB, and you will treat if the tests are positive. Sometimes large tuberculoma or large abscess may present. And here it becomes like zebra because it may not always be TB. It may be due to metastasis. It may be due to nocardia. It may be a fungal granuloma. So this is no longer a very straightforward like you see in case of tubercle or tuberculoma. I will tell another confusion which arises at times is when you see the granuloma, whether that granuloma is due to TB or sarcoid. And I'm going to tell you few features in tuberculoma that will help you differentiate TB from a sarcoid granuloma. TB granulomas are usually single, large, and there may be some new vessels or increased vascularity present on the surface. Sarcoid granulomas are not very easily visible, as you see here, and they are multiple. They are discrete, and they are not yellowish in color, and they do not have this vascularity as you see in TB granule. When you do OCT, it is very easy to distinguish TB from a sarcoid granuloma. TB granulomas, as you see here in the yellow asterisk, is a large elevation in the choroid. And there is always an involvement of outer retina, as you can see here with the arrowheads. These arrowheads indicate there is involvement of the outer retina secondary to the granuloma. Whereas when you look at the sarcoid granuloma, as you notice here, these white arrows, these are in the stroma. They are multiple. They are not as big as TB granuloma, and the changes which they produce in the outer retina are very minimal compared to what you have in TB granuloma. ICG again kind of corroborates the fact that when you see a TB granuloma, this is a large one. On the top, it is a single large granuloma, even on ICG, whereas the sarcoid granulomas are multiple, they are studded, and you can see they are discrete compared to TB granuloma. We have published the differentiation of TB from sarcoid granuloma. The median number of granuloma in the TB is generally single. Sarcoid are multiple, like up to 6, but this is an average number. TB granuloma tends to be more lobulated, whereas sarcoid granuloma tend to be more oval. And when we look at the location of the granuloma, there was a difference. TB granulomas have a tendency to be next to the vessels, perivascular, whereas sarcoid granuloma tend to be diffuse, mostly located in the stroma. Color of the granulomas, TBs, as I shown you here in this slide, they are intense yellow, whereas sarcoid granulomas are very discrete. They are not yellowish in color at all. They are very dull. And they are dull because they are located in the stroma and they are not pushing forward into the outer retina. When we look at the OCT, TB granulomas show the presence of subretinal fluid. As you see, large granuloma, and there is subretinal fluid. But sarcoid granulomas, since they are small, they do not produce that massive amount of fluid around there. So you can see on the top, there is granuloma and there is a pocket of fluid, which you can see clearly. Whereas sarcoid granuloma are discrete and subtle. Another manifestation of TB, which is very clear-cut besides the granuloma, is occlusive vasculitis. So whenever you have occlusive vasculitis, retinal vasculitis, you have to think of TB, especially in our country. This is the wide field fluorescein angiogram, which shows that there are lots of areas of capillary non-perfusion all around. And these areas of capillary non-perfusion are mostly in the periphery. So it's very important that you do a wide field. And in case you do not have wide field, at least you have to tell your photographer to go into the periphery and look at these areas of capillary non-perfusion. Predominantly, TB vasculitis is periphlebitis, though we may have the leakage from the capillary in many cases. Now, example of this case is, this is occlusive vasculitis, and when we investigated this patient for TB, the Montus was positive, 16 into 20 mn. Chest CT scan showed mediastinal lymphadenopathy, and the E-bus guided showed that there were few epithelioid cell granulomas, necrosis with lymphocytes in the background that was suggestive of granulomatous inflammation. And because of the necrosis, sarcoid was out and TB was the most possible etiology. In addition, if you see these choroiditis patches in a patient with vasculitis, and these choroiditis patches are very typically perivascular, again, it's an indicator that what you are dealing with is likely to be TB. And this is the patient with perivascular choroiditis patches, vasculitis, and again, you see the areas of capillary non-perfusion in the periphery. These areas of capillary non-perfusion have to be taken into account because these are the ones which will develop into new vascularization, NVE, NVD, and may bleed. And at that point of time, they would be diagnosed as Eales disease. But it is actually tubercular vasculitis, and Dr. Biswas has very elegantly shown that when they did the sampling of vitreous from patient with Eales disease, many of them were actually positive for Mycobacterium tuberculosis. So this patient, when we were investigated, again, you can see Montus is positive. HRCT shows fibrotic opacities, and the patient also had axillary lymph node. So axillary lymph node biopsy shows central areas of caseation necrosis and peripheral palisading histiocytes suggest with the Langerhans joint cells suggestive of TB, stained for AFP positive, so it's diagnosed as TB uveitis. Again, I will go back and show you the phenotype so that you remember. This kind of picture, occlusive vasculitis, periphlebitis, and the patches along the veins, the choroiditis, always important to rule out TB. And this patient actually had the lymph node tuberculosis, and he was not aware of that lymph node tuberculosis, but it was diagnosed by us. So there could be a latent TB sitting somewhere in the body, which you may have to look for. And this is how he looks following anti-TB treatment with steroids. Now coming to another phenotype which we described for the first time was tubercular serpiginous-like choroiditis. This was the phenotype that we described in 2003, and it made the major difference the way we used to manage our patients with serpiginous choroiditis. Before 2003, if you wonder what we used to do to serpiginous-like choroiditis was that we would see serpiginous choroiditis and we would assume that it is autoimmune in nature and we will treat it with immunosuppression. So this was the year 1999 when I analyzed our data of serpiginous choroiditis. We realized that what we are seeing is very different from what has been described in Western literature that we were following. More than 95% of our patients, despite multiple immunosuppressive drugs, were continuing to have recurrences, which was kind of unusual. So why does a disease recur? Disease recurs because there is autoimmune disease, so you increase your immunosuppression. But our patients were having nearly 100% recurrences despite giving 3-drug immunosuppression. So why does a disease recur despite immunosuppressive therapy? Either it is a recalcitrant disease, but that's a rare disease that does not happen in more than 90% of the patients, or there is an infective trigger which is inciting the autoimmune response. And when you are treating it with immunosuppression and steroids, there is a response because it's an immune response, but the disease is coming back because you have not given anti-infective therapy, and that trigger remains, in the body or in the RPE cells in this case, and is producing the recurrences again and again. So that was the time when we started looking out for a possible infective etiology. And we started looking for etiology, including tuberculosis. And that is how in 2003, we reported first time 7 patients where we diagnosed that serpiginous-like choroiditis had test positive for TB. And we just added ATT to the usual immunosuppression and corticosteroids that we were using, and the recurrence rate was reduced to 10%, which means a disease which was having 98% recurrences with immunosuppression, the recurrence rate was reduced to just 10% on the addition of ATT. So that was the power of ATT in reducing the recurrences. We did publish our initial experience in 2003, and following this, there were lots of reports from all over the world that serpiginous-like choroiditis could be a manifestation of TB. In 2012, we presented a larger data, about 105 patients, and again, our results were consistent that once you diagnose TB, once you treat TB, the recurrences are reduced to just 9.7%. That's like 10%. And 90% of the times, addition of ATT, you will be able to have a recurrence-free disease. So this was the major achievement. Now, how would you differentiate serpiginous from serpiginous-like tuberculosis? So this is the table taken from Dr. Rao's publication in Survey Ophthalmology. because Serpiginous is an autoimmune variety, and if you read the books, it says it is autoimmune. Serpiginous-like has an etiology, which could be TB in our setting, which could be something else in a different setting. So serpiginous tends to be bilateral, serpiginous-like unilateral. There is no vitreous or anterior segment inflammation in the classical serpiginous choroiditis, whereas SLC, serpiginous-like choroiditis, may have inflammation either in the vitreous or in the anterior chamber. The lesion in serpiginous typically begin in juxtapapillary area, as against serpiginous-like, which begin in the posterior pole. Now you can see this is serpiginous-like, the lesions begin in the posterior pole, and another very important feature of serpiginous-like is multifocality. You see multiple lesions, whereas the classic serpiginous does not have multifocality. That is a single lesions. And in serpiginous, you have pigment clumping at the borders of heel lesion, whereas in serpiginous-like, there is pigment clumping at the center. So we understand choroidal tubercles, choroidal tuberculoma, and serpiginous-like choroiditis are kind of the horses where you think of TB. But then there are zebras in the choroid. Now, one example of the zebra is this 57-year-old woman who has painless progressive decreased vision in the right eye for 1 month. And she has a trauma to the opposite eye, and that was kind of phthisis. She was diagnosed as sympathetic ophthalmia, and you can see at this point, she just presented like this. There was disc peripapillary fluid, and the opposite eye was kind of, phthisis and the history of trauma. So we thought of tuberculosis as sympathetic ophthalmia as possible cause, treated her with steroids and immunosuppression, and she progressed. You can see the amount of the progression. So when we tested her, it was not easy. We have tested her for almost everything. And ultimately, we offered the enucleation of the blind eye, which showed there was an acid-fast bacillus sitting there, and the PCR2 was positive for TB. So this is the kind of a zebra where you don't have a high index of suspicion of TB to begin with. But if your patient is not responding the way you want the patient to respond, then sometimes it's a good idea to repeat the test for TB and do even more invasive tests if required, because then addition of anti-TB drugs is a very specific treatment. Now, the last part before I go on to treatment is what would happen if you fail to recognize phenotype. For example, this is a patient, and I have already told you this one fits very classically into serpiginous-like choroiditis, multifocality. You do have yellow colored patches, healing in the center, going in this perivascular patches, looks like TB. But as you can see from the type of the photograph, this is the patient, which is an old patient, done old, many, many years ago. And the right eye just showed healed choroiditis. So we did PPT scan test, which was kind of equivocal, 12x12. Now we take more than 10 mm positive. But at that time, we were taking actually 20 millimeter as our, cutoff line. Chest was normal. And at that point of time, we were not really doing quantiferon gold. So believing that it is just a choroiditis, patient received oral steroids. Well, 2 months later, we saw the patient. Patient was doing fine with steroids. So she was advised to come back after 2 months. But she was lost to follow-up and came actually 1 year later. And you can see what it has become. So if you want to see again, I can show you again. This is how she had come in the left eye. And even if now, when I look at it from my experience, I know it is TB, and this phenotype is so classic that I would give her ATT. But at that point of time, we were not too sure, so we gave her steroids. There is always an initial response to steroids because it's an immune mediated mechanism. So the patient responded, but you can see what happens when there is a recurrence 1 year later when she comes. There is a huge granuloma sitting right now, and you can see the ICG, the involvement, and OCT definitely shows a large granuloma. At this point of time, we have done TB Gold, which was positive. PPD skin test 15x12, CT chest was normal, but we were wiser, gave ATT, and this is how she started responding. And of course, in some of these patients, we do add anti-VEGF therapy. The next 10 minutes, I'm going to speak on the treatment because now we know that there are different phenotypes. The phenotypes, horses, which fit very classically TB, and then there are zebras, which do not look like TB, but which over a period of time may be diagnosed as TB. So the big question which is asked all over is, when do we treat these patients? So COTS, Dr. Biswas said in his introduction, so COTS was actually is a full name for Collaborative Ocular TB Study Group. So we had established this group to develop an agreement between the uveitis experts for starting anti-TB therapy in patients with ocular TB. And this study was supported by major societies, including IUSG, IOIS, and Foster Society. So what we had done we had created different phenotypes: anterior, intermediate uveitis, choroiditis, vasculitis, panuveitis. Then there was a scenario where the patient comes from. Is it from a country endemic or non-endemic for TB? Was the uveitis first episode or recurrent? Was the uveitis active or inactive? And what were the commonly performed tests done? PPD, chest, and IGRA. These are the three tests which we took into consideration. And based on various permutations and combinations, we had 486 questions which were posed to experts who had more than 15 years of experience in managing uveitis patients. So I will not go into the details of methodology. I would just very briefly summarize that how the experts agree on treating TB uveitis. As I mentioned previously, Serpiginous-like choroiditis is a phenotype which is very, very typical for TB. So Delphi 1, this is a more than 90% consensus that if you see serpiginous-like choroiditis in a patient, which could be from any region, endemic or non-endemic region, if both immunology and radiology tests are positive, which means you have positive PPD skin test, positive IGRA, and radiology positive. And here I would like to mention, when we say positive radiology, we do not mean that there is a cavity sitting there or pulmonary TB. No. Positive radiology means that your CECT chest or X-ray chest shows an evidence of exposure to TB, which could be just the calcified lymph nodes and evidence of Gons disease, that Gons focus. So if you see any of those lesions on CT with a positive IGRA and positive Montius test, and you have a clinical picture like this, 90% of the experts would agree to treat. Scenario 2, again, you have serpiginous-like choroiditis, and both the tests, PPD as well as IGRA, are positive. Chest X-ray or CT images you have not done, they are negative, they are normal, or they are just not available to you. So even if you have these two tests positive and positive PPD is more than 10 of in duration, so then you would treat these patients with ATT. Third scenario is again serpiginous choroiditis. Patient could be from any region and you have one of the tests positive, like you'd have done Monteus come positive, and chest X-ray or CT shows some old calcified lymph nodes. You would treat, very high consensus amongst the experts to treat. Or is it just IGRA and chest positive? You would treat. When we went to Delphi 2 for some of these scenarios and for serpiginous-like choroiditis, experts felt that serpiginous-like choroiditis was a phenotype which was so typical for TB that even if you have just one test positive, which means just Monteus positive or just IGRA positive and serpiginous-like choroiditis, they would still treat. The experts from endemic region wanted to have Monteus positive, whereas experts from non-endemic region were more comfortable with IGRA. But the moral of the story was that even if one of the immunological tests were positive, they would like to treat this patient with ATT. Now comes a challenge that once you introduce ATT, this is serpiginous-like choroiditis, PPD is 18x20, chest X-ray shows calcified hyaline nodes, and you start the patient on ATT and maybe some steroids. What happens is about 40% of these patients might show initial paradoxical worsening. The black arrows indicate that the lesions which were present previously have enlarged. The arrowheads indicate that there is development of new lesions in the periphery. So this is called paradoxical worsening. So you have to know about this entity because otherwise you might panic, you might stop anti-TB treatment, and you may want to think of alternative diagnosis. This typically comes within 2 to 3 weeks of starting ATT and when the steroids have been given in low dose. Now, when you see this paradoxical worsening, what would you do? It's very important to remember that it is an immune-mediated reaction and it's not actually the active infection which is causing paradoxical worsening. So if it is immune-mediated, it has to be treated with steroids because that's where it is going to target. So courts did consider paradoxical worsening and there was consensus for concomitant use of corticosteroids. To prevent paradoxical worsening, all the experts agreed that corticosteroids can be given before or at the same time or even after starting ATT. These practices vary from different centers to center. I will not go into finer details, but corticosteroids in serpiginous-like choroiditis can be started. Many times when there is paradoxical worsening, you may have to increase the dose or you may have to give local injections of methotrexate or steroids. Though we could not achieve any consensus on intravitreal, but most of the experts felt that it should be left to the choice of treating physician. For multifocal choroiditis, we could not achieve much consensus, but when it comes to choroidal granuloma, granuloma was such a typical feature suggestive of TB that even if one of the tests is positive, there was majority consensus, more than 80% agreed that these granulomas should be treated with anti-TB drugs. And then we come to ATT with anterior uveitis. Now, problem with anterior uveitis was that based on the previous report, The experts felt that if it is a first episode of anterior uveitis and your tests are positive, you would rather wait. Do not introduce ATT in a hurry, because many times the anterior uveitis, the recurrences are not very severe and they can be managed with topical. But if the anterior uveitis becomes recurrent and all the three tests are positive, then ATT should be added. When it comes to intermediate uveitis, again, as I mentioned, intermediate uveitis, making the diagnosis of TB is not easy because it may be an idiopathic variety and you just might get a Montius positive. So intermediate uveitis is not a phenotype which is very classical for TB. Therefore, you will not jump into adding ATT just on the first episode of intermediate uveitis or with just one test positive. It will, as per the expert consensus, you should add ATT in intermediate uveitis only when all the three tests, that is PPD, IGRA, radiology, are positive and the episodes are recurrent. When we come to tubercular retinal vasculitis, you should treat with ATT only when the disease is active. This is the question again very commonly asked, that many times the patient presents to you with the vitreous hemorrhage because the disease has become inactive and now what you are dealing with is the sequelae of the disease. So when you do vitrectomy, you clear the hemorrhage and then you see some occluded vessels and some scars. And the commonly asked question is, should I give ATT? No. If the disease is not active, there is no need to give treatment at that point of time. So to summarize, Serpiginous-like choroiditis, both the immunological test positive and radiology positive, please treat. One immunological test positive, which could either be PPD or IGRA, you would still treat. One immunology, one radiology positive, you would treat. One immunological test positive and two immunological test positive you will treat, and only one immunological test, which may be PPD or IGRA, you would still treat. When we come to anterior uveitis, you will treat only if there are recurrences. When we come to intermediate uveitis, you would treat only if there are recurrences and only if the radiology as well as the immunologic tests are positive. TB vasculitis, you treat only if there is active disease. You do not treat inactive disease. For more details, both the reports are published in ophthalmology. They can be. And we also have a calculator for those of you who practice based on COTS. It's a very simple calculator which is available as an app. You just enter patient name, age, gender. When you enter the country, it automatically tells you whether it is endemic or non-endemic. So you enter which eye, what is the phenotype, like this one is serpiginoid choroiditis, and only three tests, Montius, interferon, chest or CT chest. So you enter whether it is positive or negative, and then you press on the calculator. So it will give you the result. It will say, like for Serpiginous-like choroiditis, which was entered, that there is a very high probability among experts to consider initiating anti-TB drugs. So based on this, you can actually convince your physician friends to start the patient on anti-TB therapy. So in the end, I would just like to say that recognizing the phenotype is the first and the only key step. If whatever is appearing in the eye does not look like TB, you do not bother about the test for TB. You do not treat the TB because The eye phenotype is very important. For example, if something is looking like acute retinal necrosis to you in the eye, you will not treat it with anti-TB drugs, even if the Montezuegras and the CT are positive for TB. You may have to treat for other reasons, like an autoimmune disease, you may have to treat if you want to start biologics, but then you do not label it as ocular TB. Ocular TB you label only when there are very, very typical signs of TB, which I called as horses, and then you apply the criteria and treat it. But if you are in doubt, you don't have to start ATT in a hurry. You rule out all the differential diagnosis is the most important step before you put the patient on anti-TB drugs. Rule out other possible etiologies, only then you would start the patient on anti-TB drugs. Well, with this, I'm very happy to take any questions that may be.
Thank you so much, ma'am, for the comprehensive talk and explaining it so clearly to all of us. Dr. JB, sir, would you like to comment first before we take the questions?
So that one of the common manifestation of the TB is that TB uveitis and retinal vasculitis. Conjunctival TB, corneal TB, and scleral TB is not that very common. So
Yes.
we need to introduce, and it's a vision-threatening disease.
Yes, sir.
Yes. So now we'll go on to the questions. The first question
Very
is...
clearly explained.
Thank you, sir.
Okay. So the first question is, if a patient with history of pulmonary TB 15 years back, treated with ATT successfully, comes with active panuveitis, what should be our approach?
I think if there is a past history of tuberculosis and the patient has now come with, active disease, first we look at the phenotype. When we say panuveitis, we have to be very sure that it is panuveitis. It's the granulomatous type. So once we note down our findings, what is the acute presentation this time, and it seems like TB because panuveitis could be VKH. For example, if it looks like VKH to me, I will not bother about TB. I will treat it. I will not take that history very serious. I mean, I would know, but I will not really label it as ocular TB. However, if the phenotype which the patient has come now looks like tuberculosis, I would jot down the investigations, differential diagnosis of panuveitis, always rule out syphilis, always look at sarcoid, and always, of course, the TB, sarcoid, syphilis, these are the general causes of panuveitis in our setting. So we will do the investigation. If the repeat investigations still indicate that it is probably tubercular uveitis and nothing else, then now comes the second question. There are three possibilities now. First is that the treatment that he had received in the past was not adequate. And, there is dots, there are physicians treating with one drug, two drugs, different duration, and the compliance of the patient. So first was the treatment received was not adequate, and he is having the recurrence of infection. The second possibility could be reinfection. That's another this because it was 15 years later. He might have gotten reinfected with TB bug and now producing panuveitis. And the third is the autoimmune response, which I showed briefly in my beginning, that TB bug induces the production of retinal antibodies, which themselves can cause immunological reaction. Now, whether it is the recurrence of the previous or it is the reinfection, we have to give ATT. So for the first two scenarios, we have to give ATT. Unfortunately, right now, we do not have a mechanism of differentiating the reinfection from immune response. So for all practical reasons, we would start ATT again under the cover of steroids. And if after steroids are being tapered, the inflammation comes back, it means it was more of an autoimmune response than TB. So we may need to add immunosuppressive therapy to this patient.
So, thank you so much, ma'am. We'll go on to the next question. How do we differentiate paradoxical worsening in TB uveitis from alternate diagnosis of posterior uveitis other than TB?
Yeah. So as I mentioned time and again, that before you label it as TB, you have to make sure you have ruled out every other possible etiology. Simply because your Montius comes positive, it doesn't become ocular TB. You have to label it as ocular TB. Since we do not have any direct test, it means we have automatically ruled out everything else. Now, paradoxical worsening typically comes in 2 to 3 weeks after starting ATT. So, when we start the treatment, we already know that we are not looking, we have ruled out all other possible differential. So within 2 weeks, nothing much changes. So this is a very typical scenario. It's not that it's coming after 3 months or something. It's 2 to 3 weeks period. And when you increase the dose of corticosteroids, either locally or systemically, you see the lesions regressing very slowly. So that is how you can differentiate it from an alternative diagnosis. The problem would be when you have started ATT, there is paradoxical worsening, which you label as paradoxical worsening. You add steroids and still there is no response, or you have given ATT and after 3 months you realize that it's not working. It means your diagnosis of TB was wrong. So the timing at which the paradoxical worsening comes, the lesions and the typicality makes it differentiate from other possible causes.
Thank you, ma'am. Dr. JB, sir, would you want to add anything?
So I learned paradoxical worsening from advanced eye care center Chandigarh PGI. I was missing that. I was thinking that is the recurrence of the uveitis, choroiditis, or other diagnosis. So now I diagnose paradoxical worsening. I hike up oral steroid and immunosuppressive agents, and I'm quite okay in treating such cases. It's not a much problem.
Thank you, sir. The next question is, in ocular TB, what should be the endpoint of treatment in terms of AKT duration? How to titrate duration based on clinical findings?
We cannot titrate the AKT duration. That is a very fixed regimen by the government of India. And as ophthalmologists, we can't interfere with it. So, however, you have to be very careful that under some index TB guidelines, they are giving ethambutol on a longer duration. Now that one has to be extremely careful because the chances of toxicity in an eye which is already compromised are higher. So what we are doing is we are giving 2 months of 4 drugs, which is INH, rifampicin, ethambutol, and pyrazinamide with the cover of pyridoxine, and then INH and rifampicin for another 7 months. We are giving it for 9 months by and large, but we do not have any. When we did COTS also, we collected the data. Everybody was treating it differently, So by and large, 9 months is something which Sunfik Chi from Singapore has reported that has a better efficacy. So we are following it, but otherwise you cannot customize the treatment. So it's not the end point. It's you have to give and then you have to stop. You can't keep on giving it indefinitely.
Yes.
And even your review article on intraocular tuberculosis, it was mentioned that 9 months reduces the recurrences. That was published in survey.
Yeah.
Longer.
Yes. So that is actually a very good article. I think the postgraduates should read that, Intraocular Tuberculosis in Survey of Ophthalmology, so that they can learn everything about ocular TB in that. So going on to the next question, what should be the strategy of using steroids or immunosuppression in ocular TB? When to start, when and how to taper? After stopping steroids, till how much time AKT needs to be given? Actually, the last point has already been discussed. Just when to start and how to taper, ma'am.
I think you
Steroids.
should phenotype. If the phenotype is immunologic, like Serpiginous-like choroiditis or intermediate uveitis, these are the patients who would require steroids. But if you have a large, huge granuloma or a tuberculoma sitting, it means there are actively multiplying bacilli within the eyes, so you don't have to give corticosteroid in that situation. Now let's come to immune mediated, that is the Serpiginous-like and anterior uveitis. In anterior uveitis, by and large, the topical steroids work very well. And if you add ATT, you may not have to give oral steroids. That leaves us with two phenotypes, that is vasculitis and Serpiginous-like choroiditis, where you may have to give steroids. And steroids, when given, they can be started along with ATT. And if for some reason the lesions are very close to fovea, you do not want to wait for the quantiferon and other results, you can actually start steroids and add ATT when the tests become available. So for each patient, you have to have a risk-benefit ratio. If the risk of waiting is high, there is no harm in adding steroids and add ATT later. There is again no fixed protocol, but generally within 2-3 months, the steroids are tapered off and immunosuppression is not a rule. We normally do not have to start in patients with TB. We just complete the ATT drugs and that is it. In about 15 to 20% of the patients, when the steroids are being tapered, they have a recurrence. So if these patients require more than 10 milligram of steroids to keep them, recurrence free, then we add immunosuppression, but that subset is just 15 to 20%, not very high. And you can give immunosuppression on a long-term basis, about 2 years, but ATT has to stop at 9 months.
Yes, ma'am. Thank you, ma'am. The next question is, how often do we perform an AC tap for gene analysis in suspected case of ocular TB? Gene analysis.
Not very often. The reason is we do not have a standardized, like every lab, SN lab has its own, we have our own, and the results are very variable. So we used to perform them earlier, but now we recognize, like I'm sure Dr. Biswas will agree, that you look into the eye and you know it is TB. And
Yes.
if Monteus comes positive or IGRA comes positive, you are not hesitant in starting the ATT treatment, because now we have had so much experience that
Yes.
we really do not have to put a needle in the eye to get. We do it only when we are confused in very few patients, when it doesn't look like TB. Like I said, there are zebras. It doesn't look like TB, but you are confused and it's not typical for anything. Those are the patients where we would do the AC tap, but not as a routine to make the diagnosis. I look forward to Dr. Biswas' opinion.
So I also do AC tap in little bit more than that, what you have described. But where there is a difference, I confused with the TB and sarcoid, I do the AC tap. And suppose I see Busacus nodules over there, Kopi nodules over there, and then large mutton fat KPs, hypopian. I sometimes do an anti-chamber tap to confirm the diagnosis. But supportive diagnosis is always there, Mantu, quantifer, and TB gold test. So not all the times I put the needle over there.
And plus you have to have a very solid molecular biology labs to be able to do tests. Because if your back end is not strong, you will not get much. That's also very important.
Yes, ma'am. So the last few questions, how to compare vasculitis of TB with Eales disease?
I
Same.
think Eales disease is TB only.
It's same, it's same.
Yes, so sir has given that one word answer, same. Now, the next question is about interstitial keratitis. How do we clinically differentiate viral versus TB as a cause of interstitial keratitis?
I don't know.
Even Partho sir is there.
Viral is very typically viral. You know, you have either a dendrite or the stromal involvement or I don't know. I honestly, interstitial keratitis for TB, I'm not. Partho?
No, ma'am. I think we have to ask some cornea specialists.
We don't.
I'm not sure. I'm not sure.
I don't think they
I'm not-
diagnose TB interstitial keratitis. I don't think so.
Actually, I have read one publication on TB interstitial. It involves the deep stroma, and the virus involves the superficial stroma. That's the only thing. And in a virus, you can, and in TB, it can be very close to the sclera, adjacent to the sclera, and virus can be right in the center. So these are the questions, and if I've missed anything, okay. Okay, yeah, just one more question. Clinical manifestations with atypical mycobacteria.
Yeah, that is a separate topic altogether, and atypical mycobacteria cannot be confused with Mycobacterium tuberculosis. Like Mycobacterium tuberculosis, it can produce anything, retinitis, which can choroiditis, which can be confused with nocardia, which can be atypical, corneal involvement. Even the abscesses and the loss of the eye have been reported. So I think whenever you are seeing which is something which is not usual, which is not typical, then you start looking for those organisms. And for those atypical cases, we do rely on the TABs. Because atypical mycobacterium, you cannot diagnose without the TAB and without demonstrating. So if you do not have a typical classical, then you do the TAB and you do the PCRs and molecular diagnostics for them.
Okay, ma'am, although it's 9 o'clock, if you permit, I'll ask two more questions. Just now they have popped up. One is, what if clinical presentation as active serpiginous-like choroiditis, but Monto and IGRA are negative, and HRCT chest shows old signs of TB? Shall we treat with ATT, ma'am?
As per our court's guideline, even if radiology is positive and your phenotype is very classical for TB, most of the experts would treat it. You know, so ask personally, I would not make, I don't know. I would sometimes just treat it with steroids and put it down on the file that this patient does not have a Monteus positive as yet, but the phenotype looks very typical. And many a time when you treat them with steroids and you repeat the test after 3 to 4 months, that Monteus becomes positive. And many a times I have discussion with the patient that, well, I'm starting you on steroids. If it is, I do not have a very strong evidence, because the expert consensus for only radiologic evidence was in Delphi 2, which means just 60% compared to 90% who would do it if IGRA and radiology was positive. So in these patients, what I personally follow, I put it on this, that this is the first episode. I'm not adding ATT because only one test is positive, but if there is a recurrence, then I will add ATT. So many times when there is a recurrence and you may have the conversion of Monteus from previously negative to positive, or if there is a recurrence, then the patient also understand, and I also feel better that now I'm adding ATT for a reason.
So thank you so much, ma'am, for patiently answering all the questions. And thank you, JB sir, for your expert comments also. And over to Subhav.
Thank you, ma'am. Before we conclude for today, two small announcements to make. One is the much awaited physical eye focus is back for 360-degree ophthalmology coverage for the postgraduate students from the 26th of February to March 5th. The registrations are going to close down very, very soon. So it's a sincere request to all the postgraduates to register as soon as possible and not to delay it any further. The interested students may register at www.miraevents.com. And we meet next on the 1st of February, the topic being viral retinitis by Dr. Ankush Kavli. Thank you so very much for a very healthy discussion, and we'll see you next on Wednesday. Thank you.
Thank you.
And just a small heads
Wonderful
up
talk.
to all the postgraduates that at iFocus we also have competitive sessions. So then along with learning, you have certain prizes to take home as well. So hoping to see all of you there and hoping to see all of you participate actively.
Thank you.
Thank you. Thank you very much, everyone.
Good learning.
Thank you, sir.
Thank you, ma'am.